Hello everyone, I welcome you to my YouTube channel, SMP Cats Med Skills. In the preceding videos we talked about a couple of cardiovascular diseases, among which these included, we talked about the acute coronary syndrome, we talked about acute pericarditis. Today we are going to talk about acute rheumatic fever. Acute rheumatic fever, it's a systemic connective tissue disease which follows Streptococcus upper respiratory tract infection, and it affects over 4 systems. The first system is the CVS, that is the cardiovascular, where it affects the heart. The second is musculoskeletal, where it affects the joints. The third is integumentary, where it affects the skin and the subcutaneous tissue. And then the lastly is the CNS, the nervous system. The first attack of this disease usually occurs between ages 3 to 15 years. And what are the causes? It is as a result of hypersensitivity reaction to the group A, Streptococcus throat infection. Some of the clinical features, we have arthritis, which may be migratory, asymmetric, and in more than one joint. In the other, we have acute rheumatic carditis, which presents with signs of cardiac failure such as murmurs and pericarditis features. Then we have subcutaneous nodules. We have chorea, or Sydenham's chorea, which involves the involuntary movements of limbs. Some books are going to call it St. Vitus dance, which affects the CNS. Then we have skin rash. Then we have minor signs and symptoms such as fever, arthralgia, and lab findings, where we find the assault. What are the essentials of diagnosis of acute rheumatic fever? Some of these essentials, someone has to know that it is a systemic immune process complicating group A, beta hemolytic streptococcal pharyngitis. It's basically group A, not group B. Then usually affects children between ages 5 and 15. It is rare after 25 years. It occurs 1 to 5 weeks after throat infection. And diagnosis is based on the Jones criteria, where we consider 2 major or 1 major and 2 minor, plus confirmation of the recent streptococcal infection. Then in the major criteria, it is comprised of erythema magnatum, migratory polyarthritis, subcutaneous nodules, carditis, Sydenham's chorea, or call it the St. Vitus dance, and the latter is the most specific, least sensitive. In the minor criteria, we have fever, arthralgias, elevated erythrocyte sedimentation rate, the ESR, elevated creatine protein, prolonged PRI interval on ECG, and history of pharyngitis. Those are the minors under the Jones criteria that we follow. So out of these major criteria and the minor criteria, whenever we find 2 majors, or 1 major and 2 minors, it confirms the rheumatic fever. Then what are some of the differential diagnoses? The differential diagnosis, we have juvenile or adult rheumatoid arthritis, we have endocarditis, we have osteomyelitis, since we have joint involvement, then systemic lupus erythematosus, then we have Lyme disease, then disseminated gonococcal infection, then also sickle cell disease, and hemophilia. What are some of the investigations someone can do for this rheumatic fever? Investigations, we can do blood investigations, we can also do imaging, and we can also do, basically blood and imaging. In blood, we are going to look for raised erythrocyte sedimentation rate. Then we are also going to run an anti-streptolysin or titer, call it ASOT. Then in the imaging, we are going to do chest X-ray. We are also going to do ECG. We are also going to do echocardiography. Then John's diagnostic criteria will basically look at the minor and the major as we air them out clearly. Then, next we look at the management. In the management, we basically give a bed rest until vital signs and ECG become normal. We can give salicylates and non-steroidal anti-inflammatory drugs to reduce the fever and joint complaints, but they do not affect the natural cause of the disease. Rarely corticosteroids may be used. If streptococcal infection is still present, penicillins may be indicated. And then prevention of the recurrent streptococcal pharyngitis until 18 years of age. The monthly injection of benzathine penicillin is mostly common used. So in case we are to give penicillins, the penicillins of choice we can give is Pen-V. We can call it the phenoxymethyl penicillin. And here we give it 250 milligrams. We give it 6 hourly for 10 days. And then for a child, you can give 125 milligrams per dose. Then in case someone is allergic to the penicillins, we can consider giving them erythromycin, that is a macrolide. Erythromycin, we give them 250 milligrams, 12 hourly. And for a child, we can give 125 milligrams, 12 hourly. Then another penicillin that we can give is benzathine, benzyl penicillin, where we give 1.2 mega units IM stat in an adult and in any child above 30 kilograms per body weight. Then for children less than 30 kilograms, we can give 0.6 mega units. Then in treatment of inflammation, we can give cardiac ulcer, where we give 4 to 8 grams per day. And these, some call it Hecorin 75. We give 4 to 8 grams per day until the signs of inflammation do what? Subside. And normally we give this together with magnesium trisilicate because it normally brings about increase in the what? In the gastric acidity. So we give it together with magnesium trisilicate. We give 2 to 4 tabs 8 hourly. Then in case of carditis, we can treat as heart failure. And if chorea is there, we can give sodium valproate, 10 to 20 milligrams per kilogram body weight per day. So inappropriate tachycardias in a febrile child with a recent sore throat suggests the diagnosis. So in case someone has inappropriate tachycardias and with a fever and with history of throat infection, it suggests the what? The disease. Normally there is a prophylactic dose that we give of penicillin, a course of prophylaxis that we give. We give phenoxymethyl penicillin for some good time as a prophylaxis. Since patients with this condition normally get reoccurrences, so we give them an added dose for some course of time as a prophylaxis. And we normally give still phenoxymethyl penicillin. All right, thanks for listening. Let us catch up in the next video. We'll share more about the cardiovascular diseases. Like, subscribe, comment. All the best. Yeah, so this is how erythema magnatum looks like. You can see the margins, the erythematous margins. Then this is how the nodes look like. Yeah, you can see the nodes, the multiple nodes all over the back. That's how the subcutaneous nodes look like. You can also have a look at this. That is a subcutaneous node. Then we can look also at this. So patient can present with all these multiple nodes, and you're like, what's this? So as a clinician, you should be able to get to take the history and try to assess the patient. Then we have the St. Vitus dance, so we can call it the Sydenham's chorea. This is how the patient presents. Yes, you can also see this. This is how the patient presents. You can see that asymmetry. Yeah,